This is the second video in the two-part series on JVP. In this video, we will see the abnormalities of a JVP waveform and the pathologies it correlates to. So before starting our journey of studying the abnormal JVP waveforms, let's give a couple of seconds and quickly revise the normal waveform. As we saw in the previous video, there are 5 waves or there are 5 deflections in a normal JVP waveform. 3 are positive, A, C and V, and 2 are negative, that are descents or the troughs, that is X and Y. As we saw earlier, the first positive deflection A is caused by the atrial contraction. Now, after the atrial contraction, the atria relaxes and in between there is contraction of the right ventricle that pushes the tricuspid valve into the pushes and bulges the tricuspid valve into the right atrium, so giving a small C wave, a positive. Now the X, that is the first descent, is caused by the relaxation of the atria. Now from X, the atria fills up and at V, the tricuspid valve opens and the RV passively fills. So this was the normal JVP waveform. Now we will individually consider the abnormalities of each wave. Number 1, the abnormalities of A wave, that is abnormalities of the wave caused by atrial contraction. The first one is CANON A waves. CANON A waves means they are huge deflections, they are huge A waves. These are caused by when the right atrium contracts against a closed tricuspid valve, not obstructed, it is a closed tricuspid valve. This is the RA, there is blood in the RA, the A wave is produced by the systole, that means it contracts and pushes the blood through the tricuspid valve into the right ventricle. When this is closed, not obstructed, completely closed, RA pushes the blood but there is nowhere to go. The blood cannot go into the RV because the tricuspid valve is closed. So there is a rise in the JVP and it is the rise in the A wave in the JVP, and there is a CANON A wave. This is a CANON A wave. This is a normal A wave. This is a big CANON A wave. So when RA contracts against a closed tricuspid valve, then there is CANON A waves, and these are seen in, the most common is the complete heart block. That means RA has contracted but the blood is not going here and there is no signal to the RV to open the tricuspid valve. So there is electrical problem in the electrical circuitry. So there is complete heart block is the most common cause of CANON A waves. Other are junctional rhythm, that is the rhythm produced by the AV junction, ventricular tachycardia, ventricle ectopics and ventricle pacing. The second abnormalities, giant A waves, also known as venous corrigan. These are classically described as leaping to the eye. So how are they caused? They are caused when the RA pushes blood against the obstructed tract. The RA pushes blood through the tricuspid into the RV. From RV the blood goes into the pulmonary circuit. Whenever there is obstruction at any of these level, either at the tricuspid, right ventricle or in the pulmonary circuit, it will cause a giant A wave. So what are the causes of obstruction at tricuspid valve? There is only one cause, that is tricuspid stenosis. So abnormality of tricuspid valve that cause a giant A wave is tricuspid stenosis. In the RV, now the blood has come to the RV. RV is not able to push the blood into the pulmonary circuit. So the blood comes back, causes a giant A wave. So the abnormalities of RV that in which it is not able to push the blood is cardiomyopathy of right ventricle, that is restrictive cardiomyopathy of the right ventricle. Now come to the pulmonary valve. If there is pulmonary stenosis, same story. There will be a wave, giant A wave, because the blood is not able to go forward. That is pulmonary stenosis. What happens in the pulmonary circuit? If there is acute pulmonary embolism, there is obstruction in the pulmonary circuit, that will also cause a giant A wave. So any obstruction from right atrium up till starting from the right atrium up till the pulmonary circuit, anywhere there is obstruction, there will be a giant A wave. If it is at the tricuspid level, like tricuspid stenosis, right ventricular restrictive cardiomyopathy, pulmonary stenosis, pulmonary hypertension as in seen in COPD, or acute pulmonary embolism. So what is the difference between giant and CANON A waves? Giant A waves, as we saw, are caused by obstruction. That is a mechanical obstruction. Mechanical obstruction will be a fixed entity, so it will be present in all the phases of the cardiac cycle, in all the cardiac cycles. So they are uniform in height, present in each cardiac cycle. So we will see giant A waves uniformly in all the beats. So the mechanical cause of obstruction causes giant A waves, whereas in CANON A waves, like in that are caused in complete heart block, CHB, there might be conduction in one cardiac cycle, there might not be conduction in the other cardiac cycle, like in CHB. So when the RA pushes against a closed tricuspid valve in one cardiac cycle, we will find a CANON A wave. Let's say in the other cardiac cycle, the tricuspid valve was able to open, so we will see a normal A wave. So they are variable in height and they may not be present in each cardiac cycle. Third abnormality, absent A waves. A waves are caused by atrial contraction. So any of the disease, any of the pathology that causes absence of atrial contraction will cause absent A wave. The most common and in our clinical practice is AF, that is the atrial fibrillation. In atrial fibrillation, the atria just fibrillates. It does not give proper atrial contractions, so there will be absent A wave. Let's see in the trace. The trace should have been like this: A wave, small C wave, X and V. So this part goes for a toss in the atrial fibrillation. So there is no A wave, straight away C wave. So when there are no effective atrial contraction, there is no A wave. Now the next is V or the C. This is known as a prominent CV wave. How does it look like? A wave comes here, there should be a C wave, there is, and this should have been the normal course. Here comes the V and then the Y. So this is absent. That means atria is not relaxing right away from the C wave. It is going right up to the tricuspid closure. That means no relaxation of the atria is there. That also means the blood is coming from RA to the RV. Now the tricuspid valve closes and bulges, causing the C wave, and now this should relax, but there is blood coming to the right atrium from somewhere else, which is not allowing the right atria to relax. That is not allowing to the curve to come down. So where will the blood come from? Either the tricuspid valve is leaking, the blood is going back, that is not allowing the right atrium to relax, or the blood is coming from somewhere else. There is a atrial septal defect. If there is an atrial septal defect, the blood from the LA will quickly come to the RA, and it will not allow the right atrium to relax. It will not allow the X wave to happen. So we have severe tricuspid regurgitation, the causes of CV wave, atrial septal defects and right ventricular failure. So this CV wave is caused in these three: severe TR, ASD and right ventricular failure. This prominent CV wave is also called as Lanz-CC sign. Important terminology to be remembered. Now let's see a very important valvular pathology called as tricuspid regurgitation. Tricuspid regurgitation means the tricuspid valve has closed, but it has not properly closed. It is leaking. So the blood which is supposed to go only from RA to the RV is coming back from RV to the RA through a leaking tricuspid valve. So the direction of blood should be this. The tricuspid valve should close and the blood should not come here. But in tricuspid regurgitation, what happens? The blood goes from RA to the RV. Tricuspid valve closes, but it does not close properly. So there is leaking of the blood from RV to the RA. Now let's correlate it with the JVP. Atrial contraction. We have blood in the RA. Atria contracts, throws the blood into the RV, normally causing a wave. Yes, A wave is there. Now the A wave, now the RV should contract and the tricuspid valve should bulge into the RA. This is the C wave. Normally this should be the C wave and the graph should come down to form a X, which denotes the relaxation of the RA. After this, the RA will fill passively, and at V, the tricuspid valve will open and the RA will empty. So this should be the normal waveform. Now, when the RV contracts, what happens? The blood which should go exclusively into the pulmonary circuit quickly comes into the right atrium also. So the right atrium never empties completely. So there is no X. There is no X. It becomes another positive wave that is known as the CV wave. And at V, the tricuspid valve opens, the pressure drops, and the RA empties into the RV. So since the RA never empties, there is no X wave in tricuspid regurgitation. The RA never completely empties. So in tricuspid regurgitation, we have absent X. These are the characteristics. These are very frequently asked questions in your med school or in your NEET or MLE examination. Absent X, prominent CV, and there is no problem in the Y wave. So it falls normally. Now, before proceeding to two other important pathologies, let's solve a multiple choice question. I will just read out the multiple choice question. We'll make some diagnosis in our mind, and at the end of the video, we will discuss the MCQ in detail. So let's see it. A 28-year-old gentleman underwent a mitral valve replacement. The surgery was uneventful, and the patient was shifted to the intensive care unit. The initial parameters of the patient are shown in the figure below. This is the figure, the initial parameters, the heart rate, the blood pressure, the central venous pressure. These are shown. In the first 3 hours, the patient drained a hemorrhagic fluid. After cardiac surgery, we put in the tubes in the mediastinum and the pericardium so that if there extra blood is there, it should come outside. So in the first 3 hours, the patient drained a hemorrhagic fluid at a rate of 100 ml per hour. However, in the 4th hour, the drain suddenly stopped. The blood pressure started to fall, and it was difficult to manage even with high dose of vasopressors. The right atrial pressure, which at the time of shifting was 5 cm of water, suddenly rose up to 15 cm of water, and the urine output of the patient also dropped. What is the probable right atrial pressure trace of the patient? So there are 4 choices. First, we have to establish the diagnosis of this patient. Then we have to correlate the diagnosis with one of these 4 choices. Now, 2 important pathologies we will study: cardiac tamponade and chronic constrictive pericarditis. First of all, cardiac tamponade. What is cardiac tamponade? This is the pericardial sac around the heart, and there is a there is fluid in this pericardial sac. This is what we call cardiac tamponade. It is different from pericardial effusion. If this massive pericardial effusion is causing hemodynamic effects, is causing hemodynamic instability, then it becomes a cardiac tamponade. So what happens in the cardiac tamponade? The basic pathology is right ventricle is not able to relax and fill passively. That means the right ventricle is not able to fill passively by itself. The right atrial pressure does not fall. Let's correlate it with the JVP waveform. A normal, C, X, V and Y. This part is a normal waveform. Now the RA pressures do not fall. The RA pressures are high, that is JVP is high. So if this is the baseline, we have a high JVP. This is A, atria contracts, no problem. C, RV contracts, tricuspid valve bulges, no problem. The floor of the RA is pushed, it descends down and it becomes an X descent, no problem. The RA passively fills with blood from SVC and IVC, there is no problem. And we have a V wave. Now tricuspid valve opens and the RV has to fill passively. Since there is pressure of fluid from outside, the RV is not able to fill passively. So there is no Y descent. Y descent is absent. Y descent is caused by after the tricuspid valve opens at V and the RV fills passively. Since there is pressure from outside, if this is the RV and this is the pericardial sac, there is so much fluid in the pericardial sac and it is so much tense that it compresses the RV from outside. So the RV is not able to fill passively. If the RV is not able to fill passively, that means we don't have a Y wave. We don't have a Y descent. So the characteristic of cardiac tamponade, we have raised JVP, prominent X. There is no problem in relaxation of the atria. There is a prominent X, but there is problem in passive filling of the RV. The RV does not fill passively due to the compression of RV from the tense fluid in the pericardial cavity. So there is absent Y. So this question comes in the exams. What are the characteristics of cardiac tamponade in JVP? Prominent X and absent Y. Now let's see the other pathology, chronic constrictive pericarditis. What is the basic pathology? Two important things. The pericardium is stiff, it does not relax properly. The other thing is there is no external compression from outside like there was in cardiac tamponade, in which the tense fluid was compressing the RV from outside and causing hemodynamic instability. The other thing is the right atrial pressure is increased, since the RA is not able to get more than normal blood, and the RV filling pressures are high. So let's correlate it with the JVP waveform. This is the normal JVP waveform: atrial contraction, tricuspid bulge, descent of the RA floor, opening of the tricuspid valve, and passive filling of the RV. In the cardiac tamponade, what we saw, there is no passive filling of the RV since there is compression of the RV from the outside. Let's see what happens in the constrictive pericarditis. If this is the baseline, first thing, JVP is increased. So we have a high JVP, no problem in atrial contraction, no problem in tricuspid bulge, no problem in relaxation of the RV of the RA, no problem in the descent of the RV floor when the RV contracts. So we have a X, normal X, which comes down to the baseline. So there is a prominent X. The RV and the RA fills. It will not fill more than its normal capacity, but the RA will fill. RA will fill and the pressure will rise up to the V. At V, the tricuspid valve will open and the right ventricle will be able to fill passively. In cardiac tamponade, there was a problem in the passive filling of the right ventricle. Therefore, there was no Y. But this is not the case in chronic constrictive pericarditis, in which the RV can normally fill passively. So the RV will fill passively and the RA pressure will go down and we will have a Y descent, and it will right up to the baseline. So we have a prominent X, we have a prominent Y. If we see this waveform, this looks like a W. So it is also called as W sign or the M sign. It is also known as Frederick sign. So three characteristics of CCP: increased JVP on respiration. This is known as KUSSMAUL sign. In the next slide, we'll see what is KUSSMAUL sign. Prominent X and prominent Y. In case you are not able to correlate the things, if you can remember it with a simple mnemonic. P stands for pericarditis, P stands for prominent X, and P stands for prominent Y. So chronic constrictive pericarditis has two P's. It has a P in itself, pericarditis, and two more P's, prominent X and prominent Y. Now let's see what is KUSSMAUL sign. KUSSMAUL sign was first identified by Adolf KUSSMAUL. What happens in a normal inspiration? KUSSMAUL sign tells us about the relation of the JVP with the inspiration. Normally JVP tends to fall during inspiration. We will see while the JVP will fall during the inspiration. But KUSSMAUL sign means there is increased in jugular venous pressure during inspiration. So what happens normally? When we inspire, the intrathoracic pressure becomes negative. When the intrathoracic pressure becomes negative, the blood tends to suck into the thorax. So the blood sucks into the thorax, this vertical column drops. So normally there is fall in JVP during inspiration. Negative intrathoracic pressure, vertical columns in the right internal jugular vein falls, JVP falls. The venous return increases, more venous return into the right side, and RA and eventually RV accommodates the incoming blood. This is what happens in the normally. So any condition that restricts RV filling, the filling of RV is not proper, that causes a positive KUSSMAUL sign. These conditions are chronic constrictive pericarditis, restrictive cardiomyopathy, and RV dysfunction. Three causes: pericarditis, constrictive pericarditis, RV cardiomyopathy, and RV dysfunction. In case you want to remember it, you can follow this simple mnemonic. K stands for KUSSMAUL sign, K as in C, constrictive pericarditis, and C as phonetically K, cardiomyopathy of the RV. So KUSSMAUL sign, constrictive pericarditis, and cardiomyopathy of the right ventricle. So why there is no KUSSMAUL sign in cardiac tamponade? This is again the normal physiology. In inspiration, negative intrathoracic pressure, vertical column of the JVP falls, there is increased venous return, and the RA and RV eventually accommodate the incoming blood. So in cardiac tamponade, there is no problem in the right atrium receiving blood. The right atrium adequately receives blood. There is no restriction, there is no problem in the right atrium receiving the blood. It relaxes properly and receives the blood properly. So there is fall in JVP. That is normal. So KUSSMAUL sign is negative in cardiac tamponade. So we saw the abnormal JVP waveforms. We saw the abnormalities of A wave, giant A wave, CANON A wave, absent A wave. Then we saw CV wave. Then we saw three important pathologies: tricuspid regurgitation, cardiac tamponade, and chronic constrictive pericarditis. So before we end our video, let's quickly revise our question and see what the answer is. I will not go through the question. I will not read the question again. Let's see what are the important points. First number point, the drain stopped completely. The patient was bleeding, the blood was coming through the drains, and if it would have been normal, then the drain would have slowly stopped, 100 ml, 75 ml, 50 ml, and eventually over a period of time it might have stopped. But if it stops suddenly, that means something fishy is going on. The drain stopped suddenly, blood pressure started to fall. The right atrial pressure, that is a JVP, or the right atrial pressure or the central venous pressure, quickly raised from 5 to 15. The patient did not respond to high vasopressors. The urine output dropped. That means we are looking at something that is compressing the heart, that is causing the heart to give a low cardiac output. The drain stopped, that means the blood is collecting inside. Now the blood is collecting inside, the heart is not able to pump properly, that means something is compressing on the heart. The accumulated blood is compressing on the heart, that means we are looking towards cardiac tamponade. Let's see all the four choices. A, one is a normal waveform. Now come to C. C, this is CANON A waves. If we are looking towards cardiac tamponades, A wave are normal. Now B, what can we see? If this is normal, we have a high JVP. Okay, this is cardiac tamponade. A is normal, C is normal. X is here, we have a V here. And what is this? Y is not that prominent, or rather Y is absent. So we have an absent Y in choice B. Let's go to in D. If this is the normal JVP, okay, we have a high JVP. That's fine. Tamponade has high JVP. But what is this? We have a prominent X. Oh, we have a Y also. So prominent X, prominent Y, all the P's, that is pericarditis. So D is pericarditis, this is CANON, this is normal, and absent Y. Absent Y with a prominent X is a feature of cardiac tamponade. So the answer is option B. So in this video, we saw the abnormalities of JVP waveform and we tried to correlate various pathologies with their specific waveforms. Hope you found this video informative and you were able to grasp the concept of JVP. I'll be coming back with more such videos on the various concepts of cardiovascular medicine. Till then guys, stay focused and study hard.